Hello and welcome to MD311 Medical Care Provider. This session is on emergency childbirth or how to catch a baby. By the end of this session, you will be able to define a number of terms related to childbirth, list and perform the steps of an uncomplicated delivery, and calculate an Apgar score on a newborn. You will also be able to list 2 early pregnancy emergencies and non-pregnancy gynecologic emergencies. One of the basic principles of determining whether there are early pregnancy emergencies is to determine whether or not there's a pregnancy. So any female of reproductive age who's got a genital complaint or abdominal pain complaint, unless they have no uterus or no ovaries, they get a urine pregnancy test. Even if they've had a tubal ligation, had their tubes tied, they can still get an ectopic pregnancy. And in fact, if they're pregnant, it's much more likely to be an ectopic pregnancy. So only if they have no uterus or no ovaries do you not get a pregnancy test, because that divides the issues into early obstetric emergencies or gynecologic emergencies. And sexually transmitted diseases are discussed elsewhere. So if your urine pregnancy test is positive, then you're going to assume it's an obstetric emergency. And you essentially are making a new diagnosis of pregnancy. And the problem is that the pregnancy can be in the uterus or outside of the uterus, what's called an ectopic pregnancy. And outside of the uterus, it can be anywhere. Most commonly, it's in the tubes, but because of the way the fallopian tubes are related to the ovary, that fertilized egg can actually be anywhere in the abdomen. They can attach to the bowel, they can attach anywhere. And if the patient's having pain, you have to assume the pregnancy is outside of the uterus. The problem there is that if it's outside of the uterus, it can stretch blood vessels wherever it's growing, particularly in the fallopian tube, and rupture, and the patient can bleed to death. So any patient with abdominal pain who has a positive urine pregnancy test, so it's a newly diagnosed pregnancy, you need to assume that they have an ectopic pregnancy that's essentially a ticking time bomb waiting to rupture and cause the patient to bleed to death. If they're having vaginal bleeding, they may be having what's called a miscarriage, where they're losing the pregnancy, and 50% of all pregnancies end in miscarriage, most of them so early that the patient never knew they were pregnant. But even if it's later, if they haven't had an ultrasound to prove that the pregnancy is inside the uterus, vaginal bleeding and abdominal pain with a positive pregnancy test, you assume that that's an ectopic pregnancy. You can't tell, and you have to assume that they're having a life-threatening gynecologic obstetric emergency. So what do you do if the patient has abdominal pain in a newly diagnosed pregnancy? You talk to medical control. These patients need to be evacuated. If they have completely normal vital signs, they have mild pain, they don't have any bad findings on their abdominal exam, preferably they're evacuated in 24 hours. You could conceivably extend that to 48 to 72 hours if they continue to remain stable. But if they have abnormal vital signs, their abdomen's very tender, they have percussion tenderness, rebound or guarding, they need to be evacuated immediately. The same is true with vaginal bleeding and newly diagnosed pregnancy. You're assuming it's an ectopic pregnancy, and if they're sick in any way, you're evacuating them immediately. And if they're not sick, they still need to be evacuated because you're assuming that they've got an ectopic pregnancy that just hasn't ruptured yet. Now, if they're not pregnant and they are having abdominal pain, you're back to any patient with abdominal pain. So all the things that you would worry about, appendicitis, bowel perforation, any of those things could be going on. But there are some specific gynecologic emergencies that you want to keep in mind. If the patient's having vaginal bleeding and they're not pregnant, talk to medical control. Evacuation is going to depend on how much bleeding there is. How do you know how much bleeding there is? You ask the patient, but you have to be very specific to quantify that. There are some patients who won't change a pad until it's completely soaked through and they've started to soak their pants with blood. There are other patients who, as soon as they get a few drops of blood on a pad, will change it out. So they can both tell you they've changed 10 pads in one day. For one person, they may have lost a quarter of their blood volume. For the other person, they may have lost less than a teaspoon of blood. So you need to ask how soiled the pads are, how many tampons they're using, and get a really good estimate of that. And if they've got abnormal vital signs and there's a lot of bleeding, then medical control will advise you to evacuate the patient. If evacuation isn't possible, one of the things they may advise you to do is find out if there are any oral contraceptives available on the ship, because high-dose oral contraceptives can be used to stop abnormal vaginal bleeding. And if it's an emergency, you may have to go polling female crew members to see if they have anything they can share. Now, the other abdominal pain gynecologic emergency you're going to worry about is lower abdominal pain. And that's in the suprapubic region, down in the pelvic region. The ovaries hang on little connections to the abdominal wall that they can twist around. And if they twist around those connections, they twist around their own blood supply. And over hours, the ovary dies. This is incredibly hard to diagnose. Any textbook you read on ovarian torsion will tell you that they have severe pain. It's on one side, it's in the pelvic area. It comes and goes as that ovary twists and untwists, or torses and detorses on itself, and it's severe pain. And when it's not twisted, they have no pain at all. Well, that's great, but that very rarely happens. The reality is that most of these patients have ongoing lower abdominal pain. It's an achy soreness. It may wax and wane some, but it rarely goes away completely. And for most patients, it's not diagnosed in the first 24 hours. And unfortunately, after 24 hours, the ovary has died. And so the management for it is to remove it surgically. Although if it's not removed, it actually will reabsorb on its own. And so there are probably many ovarian torsions that have never been detected. And part of that is because losing one ovary doesn't affect fertility at all. The ovaries generally alternate in producing eggs once per menstrual cycle, but if one ovary dies, then the other ovary can actually take over and produce all the eggs for that patient. We'll start with some definitions so that you're able to speak clearly and correctly about what you're doing when you're delivering a baby. So a fetus is a developing unborn baby, and the uterus is the organ in a female that holds the developing fetus. It's very muscular, and it's designed to eject the fetus during labor. The birth canal is the lower part of the uterus and the vagina that the fetus passes through as it's born and becomes a baby. The placenta is an organ that attaches the fetus to the wall of the uterus, and its job is to get nutrients from mom's circulation to the baby, to the developing fetus, and in return to get rid of fetal waste products and pass them back through mom so mom can get rid of them in the usual ways that adults excrete waste. The umbilical cord is what attaches the fetus to the placenta, and the amniotic sac is a fluid-filled sac that completely surrounds the fetus in the uterus. Between the back of the vagina and the anus is an area of skin called the perineum. This is important because it's an area that often gets torn during the delivery. If the patient is crowning, it means the baby's coming now. That's bulging of the head through the vagina. You can see the top of the head, even when the mother is not contracting. Bloody show is mucus and blood from the vagina at the beginning of labor, as opposed to breaking water, which is when the amniotic sac fluids and sac ruptures and the amniotic fluid comes out from the vagina. And the presenting part is the first part of a delivering fetus that comes out. And you hope that it's the head, because that's the easiest, and you really hope it's not the bottom with the legs folded up, because that's very difficult. While most pregnancies go just fine, there are a number of things that can complicate a pregnancy, and we'll talk about each of these. In a miscarriage, a fetus is delivered before it's able to survive outside of the uterus. The major issue for you is that if there's any parts that are retained, particularly the placenta, the patient can have uncontrolled hemorrhage, and the treatment for that is to contact medical control, start an IV to give IV fluids, and evacuate the patient. If it's a simple, uncomplicated miscarriage, you don't necessarily have to evacuate the patient. A pregnant patient can also suffer from what's called eclampsia, which is a pregnancy-related seizure. We don't actually know for sure why these happen, but they're life-threatening to both the mother and the fetus. Your treatment here is airway, breathing, and circulation control, and contact medical control. The only medication you're going to have that you'll be able to give is diazepam, an anti-seizure medication, and you need to evacuate the patient if that's the case, that they're having an eclamptic seizure during pregnancy. Premature delivery is sort of the flip side of a miscarriage. The fetus is beyond 23 weeks, and so it's theoretically able to survive outside of the uterus, but it's delivered before it completely develops. And this is a real problem. The delivery will be very easy. These are very small fetuses, but if it's under 30 weeks, unless you happen to have a neonatal intensive care unit right next door, chances are pretty good that the fetus is going to end up dying before you can get it to care. Your hope is always that the head delivers first, but sometimes the wrong parts can show up. So the umbilical cord can prolapse. That means it falls out of the vagina before the baby's delivered. And this becomes a problem when the baby's head starts pressing against it, compressing it, and cuts off its own blood supply. So what you need to do is hold the baby's head off the cord and hope that the baby will be urgently evacuated, or that you can deliver the head so that the baby can start breathing on its own, be supported on its own, and not be relying on the umbilical cord. Sometimes a limb, arm or leg, or the buttocks in a breech situation present first. If that's your situation, talk to medical control. They'll have to walk you through the delivery. It becomes much less easy. If you've got a woman who's later in her pregnancy and she starts to have painless vaginal bleeding, you need to be very concerned. This is called placenta previa. The placenta, which is that organ attached to the fetus by the umbilical cord, grows into the wall of the uterus to get nutrients. So there's a huge blood supply, and if it's covering the birth canal, it'll tear from the wall of the uterus and start bleeding, and so the patient can bleed to death. Treatment for this is to contact medical control, establish an IV, and get the patient evacuated as quickly as possible. If the fetus is under a stressful circumstance, its bowels will let loose. The first stool is called meconium, and it's in the amniotic sac, so the fetus is breathing it in and is covered with this, and that's a sign when you see a green stool-covered baby like this that there was fetal distress, and you can expect that the newborn will also be in distress. So your treatment is maintaining the airway, breathing, and circulation of the fetus, and talk to medical control about what you need to do. Alright, now let's switch to labor. Labor is a three-stage affair. The first stage occurs with the first true uterine contraction, and women can have false contractions long before they have their first true contraction. But in the true contractions, their body is gearing up to deliver this baby. And it ends when the cervix, which is the bottommost part of the uterus, essentially, that protrudes into the vagina, completely dilates up to about 10 centimeters so the baby can fit through. The second stage starts at that point and ends when the infant is delivered, and then the third stage starts when the infant's delivered and ends when the placenta is delivered. So you have to remember that both the infant and the placenta need to be delivered to complete labor. Now, hopefully you'll have a pre-made obstetrics kit available to you in the event of a delivery. It may say emergency childbirth kit or something similar. It's going to be a fairly generic kit, so take a look at the outside. They're usually sealed in plastic and they list their contents. And usually they'll have these items in there which are useful for delivering the baby. What you really need at the end of the day, a pair of gloves for you, preferably a gown because it's a pretty messy affair. And as you deliver the baby, you need the ability to tie the cord close to the fetus, tie it a little bit further away, and something that you can cut between those two ties to free the fetus from the placenta. So if you think that someone is in labor and going to deliver, first thing you need to ask is, are you pregnant? And if they say no, make sure you confirm that. If they say yes, which they probably will, how far along are you? That will tell you how well developed the fetus is going to be. You ask, are there contractions or abdominal or back pain? How often does it happen and how long does it last? The more frequent it is and the longer it's lasting, the closer to delivery you are. Is this your first pregnancy? Typically, it takes a lot longer to deliver the first baby than the second, third, or 10th. And so if it's the first, you know you have some time. If it's the 10th, the baby's coming now. Any problems during the pregnancy? That gives you a sense, again, of the risk to the infant. And do you feel like you need to move your bowels? If they feel like they need to move their bowels, don't let them. That's pressure of the fetus against the rectum, and if they go to the bathroom, there's a reasonable chance they'll deliver the fetus in the toilet, and you don't want to deal with that. And then, do you feel like you need to push? And they may feel like they need to push, but if they're not having frequent or regular contractions, they shouldn't. If they are, then it's probably time. So, if the baby's coming now, the contractions are 2 to 3 minutes apart, you look and you see the head of the baby at the vagina, that's called crowning, or there's severe pressure in the vagina or rectal area, or the mother lets loose with a primal scream, get ready to catch the baby. It's coming now. Hopefully, the mother knows how many there are. That's important to know as well. You want to talk to medical control if you have time. Don't let mom go to the bathroom. Don't tell her to hold her legs together. The baby's coming. And don't boil water. All your equipment should be sterile. Be sure to follow the link on the page in the module at the end of this session to watch a delivery. So what do you need to do? You need to put on your gloves, your mask, your gown, and your eye protection. Mom can either lie on her back with her knees drawn up and the legs spread apart, or she can squat. And if you're in a situation where she can squat, that makes gravity her friend and yours and makes the delivery much easier. You want to create a clean field around the vaginal opening. It doesn't have to be completely sterile, but you want to make sure that there's not dirt or other contaminants. Less for the fetus, which should do okay, and more for mom so that she doesn't get a post-delivery infection. So the head comes out. Put your fingers on the bony parts of the skull. Just the fingertips. Don't push on the face or the soft areas, the fontanelles. You want to be on the bones. And then you're going to very gently let the infant come out. And your job is not to control the direction of the delivery. Your job is to prevent an explosive delivery. If the head's coming out and the amniotic sac is still intact and the woman hasn't broken her water yet, you can use a clamp to puncture the sac and then push it away from the head and mouth as they appear so that the infant can start breathing. Once the head is delivered, put your fingers around the neck and make sure the umbilical cord isn't wrapped around the neck. If it is, you need to slip it off if you can, and if you can't, you need to clamp it and cut it and then unwrap it. Once the head is delivered, support it. You'll have a bulb suction, ideally. You want to suction the mouth 2 or 3 times and suction the nostrils. Try not to hit the back of the mouth. You don't want to cause the baby to gag or vomit. Once the head and the shoulders pass through, the rest of the body slides right out. Support them with both hands. Babies are really slippery. Don't drop the baby. When I did one of my first deliveries as a medical student, the OB attending was standing right behind me. I had the towels in my hand. Baby came out. I dried the baby off, cut the cord. I turned, my back was to the OB, to hand the baby off to the nurses, and I dropped the towel on the floor. Not the baby, but the towel. And the OB nearly passed out. He thought I had dropped the baby. But I didn't. Nonetheless, be very careful. They're really slippery. So now the baby has slid the whole way out. You're supporting the head, the torso, and the feet. Wipe any blood or anything else away from the mouth and nose and resuction. And then wrap them in a warm blanket or place the baby directly against mom and wrap them both up to warm them up. Next, you need to free the baby from its attachment to mom. It's time to cut the cord. So you want to clamp the umbilical cord about 10 to 15 centimeters away from the baby. And then you want to tie or clamp the umbilical cord about 5 centimeters from the baby. And once the cord stops pulsing and there's no more significant blood flow going through it, cut between the clamps or ties, and now you've separated the baby from the placenta. You then need to do what's called an Apgar score, and this is a universally recognized score that describes how a baby's doing at birth, that is 1 minute after delivery, and at 5 minutes. So you've got appearance, which is the color, pulse, which is the heart rate, grimace, which is the irritability, how it responds to stimulation, activity, its muscle tone, is it floppy or nice and strong with active movement, and respiration. So Apgar, appearance, pulse, grimace, activity, respirations. Hopefully, if you're using a pre-made kit, it'll have a little Apgar card in to help you score. At that point, if you don't have to resuscitate the infant, you're done with it. Wrap it up, give it to the mama, let her take over, record the information and notify the appropriate authorities. You will need to deliver the placenta. Remember, labor isn't over until the third stage finishes and the placenta is delivered. So you now have a tied off umbilical cord, which is hanging from the vagina. The placenta gets shed from the vaginal wall over the next half an hour or so. So you don't want to yank or tug on the cord, because if you break it above your tie, the mother can bleed to death from it, particularly if it breaks off inside of the body. Once it starts to deliver and you can see it starting to move out, you can apply some very gentle traction to the cord, but you're not yanking or pulling. And if you're going to do that, talk to medical control first. Please watch the video of a delivery and then complete the knowledge review for this session. If you have any questions, please contact your instructor. Thank you.